Okay, so you should all be able to see my slides, and I hope I'm audible enough. So let me begin. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I would like to thank organizers once again for their kind invitation. So title of this talk is Cholestatic Liver Diseases, Principles of Management. Now, unfortunately, we have a time limitation here, and I would therefore be able to give you only a drone's overview of cholestatic syndromes. I will try to just touch upon the basics of cholestasis, talk about some cholestatic liver diseases that we encounter here in West frequently. I appreciate what Dr. Nazish Bhatt said earlier that she had only seen a handful of patients with hemochromatosis, whereas we see a lot of them in our practice. Likewise, cholestatic disorders is something which we have a good cohort of patients, and it may not be something that you commonly see in your practice. It's early in the morning, and it's unfortunate that I cannot be there with you. But if I go back 2 years ago, 3 years ago, by this time, that is day 3 of the conference, I had nearly 20 cups of tea, which was keeping me awake, and I was enjoying the giggle, laughter, chats. And COVID has devastated our lives. It has certainly affected my coffee intake, and obviously I'm missing out on the company and laughters and words of wisdom. So let me just take you through some of the basics of cholestasis. So cholestasis is, as we all know, is an impairment of bile formation and or bile flow, which may clinically present with fatigue, pruritus, or it's in most severe form as jaundice. Now, etiologies of cholestasis, cholestatic liver disease, are related to the site of hepatobiliary insert. So we know that bile production is quite a complex process that involves hepatocytes, cholangiocytes, a number of different bile acid transporters, which coordinate in bile formation with various surface receptors on cholangiocytes that regulates cholangiocyte secretions and function. So cholestasis starts at hepatocytes and ends at large bile ducts. There are myriad of processes from drug, sepsis, inflammation, genetic etiology that leads to the presence of biliary constituents into the serum, and that's how we define cholestasis. Cholestatic syndromes, we can divide them as neonatal or adult, or on the basis of bilirubinostasis or cholestasis. Now you will see that maybe in the late stage, we may not be able to differentiate on the basis of histology if the stasis is cholate or bilirubinostasis, because by that time you would see both bilirubin and cholate stasis in histological specimen. But it's what we're looking for is the deposition of the bile fragments in the hepatocytes, hepatocellular, clavicular, and Kupffer cells. There's a long list of cholestatic syndromes, and just in the interest of time, we'll just try to focus on some of the common pathologies that we encounter here. Principles of management across the board would include stratifying our patients using the biochemical and prognostic criteria. We would stage the disease, monitor progress, manage our patients actively in order to prevent the complications, and survey these patients. And when we talk about surveillance, the big C word comes into mind, and that stays on the forefront of our hepatoma surveillance pathways. Now, very briefly about DILI. I know we've discussed this already, and we fortunately do not come across many patients of acute liver failure due to DILI, and mild liver injury is common. If you look at the data from the Spanish DILI registry, it would again not come to you as any surprise that the hepatic metabolism in those who were more than 60 years of age was indicative or was guiding toward more of a cholestatic liver injury. So although when we talk about the drug signatures, and we know that drugs are like doctors as well, and vast majority of these do not have a sufficiently distinct signature pattern that are consistently recognizable. Now, the R factor is important, and we know when it's less than 2, it suggests a cholestatic pattern of liver injury, but we do have to rule out other conditions, pancreatic malignancies, cholangiocarcinoma, which can cause cholestatic pattern and hence may find the same drug signature, which may not be due to the drugs. There are some very nice online portals available which you can use to guide management of your patients. Now, this is one of my favorite slides borrowed from Professor Hirschfield. And it's because this family of autoimmune disorders have this disease kinship. And when we look at the immune biology, we come across that the environment is the big elephant in the room. And I guess that is the reason we don't tend to see much of it in the East as compared to the West. So there is a complex interplay between the genetic and the environmental factors, which is involved in the development of cholestatic disorders. Regional geography, there's a bit of heterogeneity which exists, and there are studies demonstrating that there are a cluster of cases in areas of low income, increased pollution, toxic waste product, and that is when they're looking at the data from the West. With the disease kinship, you'll see this linear linkage of epigenetics, bile acid regulation, inflammatory cytokines, and estrogens receptor signaling pathway, which leads to the formation. And now we have additionally this IgG4 related disease. So let's focus on PBC for the next few minutes, and the features which are common across the board are pruritus, fatigue, which leads to the reduced quality of life, and in some patients, it may be severe enough to cause the cognitive impairment. So please do not regard your patients as mad. There is always an underlying process which leads to the behavior that is exhibited when we are facing them. There's also studies out there looking at the MRI scans, and this was where they looked at the MRI scans 6 months post-diagnosis, and they were able to see the MRI changes in the brain 6 months post-diagnosis in patients with PBC. So there is this cholestasis-induced dementia, and this concept is being studied further. Do we have a typical patient? I don't think there is any such thing called typical patient with PBC. Patients are mostly female, middle-aged, with positive serology of AMA with elevated IgM. The imaging and histology is not very helpful in most of these cases. Symptoms, we've just briefly talked that they may present with non-specific tiredness, fatigue, pruritus, and they have association with other autoimmune conditions. The important thing to bear in mind is that we have to identify patients who are at higher or who are at a great risk of disease progression, because this is a group of patients who you may have to concentrate your efforts. So we may not regard this as a very worrying pathology or cases that you need to keep a close eye on. But if you are able to identify those who are at increased risk of progression, then you are able to prevent a lot of morbidity and mortality. So the first thing is first, we do want to make a confident diagnosis of PBC, start these patients on treatment as soon as possible. So that is the key message, and that is directly related to the overall outcome of these patients. So diagnose confidently, start treatment early, which is the treatment is a waist-based 13 to 15 mg per kilogram body weight, and then follow these patients. And if there's signs of poor response to the treatment, then you can consider second-line treatment. Manage symptoms actively. Symptoms management is a challenge, and we'll touch upon it a little later in this presentation. But a close involvement, close working relationship with the patients is the key. As we've discussed, risk stratification is important. Then you can identify which patients will need second-line treatment and may need referral to onward liver centers. Once a patient has developed a cirrhosis, then they have to be included into the hepatoma surveillance pathway, as we would do for any other etiology. Now, the goalpost is shifting. I mean, we've always talked about normalizing or bringing ALP into 1.5 or 1.6 upper limits of normal, but things are changing, and we know there are more data coming out which is showing linear linkages with the normalization of the liver enzyme, normalization of the liver. So when we are seeing our patients or when we are treating them, the aim here is to get normal liver biochemistry, normal bilirubin levels. What is available and what's on horizon, again, maybe more of an academic in the settings that most of you work, but we do have to bear in mind that the available products at the minute, obeticholic acid and bezafibrates, obeticholic acid and FXR agonist is an evidence-based approach. It is licensed product, however, it is expensive, and there are patients who do not like it the moment the word pruritus comes out of my mind. Therefore, we have an alternative bezafibrate, which is a PPAR. It is not yet licensed, but it is effective with less risk of causing pruritus. Now, in terms of, as I said, there's plenty of data out there, but I chose this study because I thought this depicts the underlying mechanism and underpins why should we be choosing OCA when we have availability and there are resources support that. So this randomized placebo-controlled crossover PET study of 8 PBC patients demonstrated that OCA enhanced secretions of conjugated bile acid from hepatocytes into biliary canaliculi. The OCA also increased the hepatic blood perfusion and uptake clearance of conjugated bile acids, and therefore reduced the time the hepatocytes were exposed to potentially bile acid. So overall, it reduced the burden of bile acid in the liver. I don't think this can be easily repeated because we're not very keen on doing these nuclear medicine studies, but I thought it was a nice proof of concept. There's a lot of talk about using budesonides in patients who are with high risk. So I think this very nice paper again from Gideon's group showed that when they selected high risk patients who were not responding to the ursodeoxycholic acid with no background cirrhosis, these patients, when they were treated with budesonide in combination with urso, they did show a response in when it comes to improvement of biochemistry. However, the liver histology did not improve. Now, another very important question that gets asked is about the overlap syndrome. So my answer to this is mostly that the first thing is we try to make the diagnosis confidently at the beginning so that we can start our patients on the right treatment. Now, the overlap syndrome, which are described in different ways, immunoserological, radiological, biochemical, or histological overlap, they do not really exist. At least we do not see a lot of them in our practice. And I think, as guess, it goes down to the same point that we try to diagnose our patient confidently early on and try to start them on the right treatment. Also, remember in mind that there is a disease process which will declare itself with the passage of time. Pruritus caused by pruritogens, there are different mechanisms. It gets secreted into the bile, it gets transformed into the gut, it gets accumulated into the circulation, and then it affects the endogenous opioids and serotonergic system. And we have a number of medications available which affect on different pathways and hence can be utilized to help our patients' pruritus. And there is, if you look at the European or the American guidelines, there's a nice letter available which helps us to manage our patients' pruritus effectively. Rifampicin seems to be the one which has the most evidence available. There's a lot of talk about its hepatotoxicity. That is not really true in the clinical practice. If you start it on a low dose, 150, and then gradually increase the dose to 600. We do ask for the monitoring, but the actual hepatotoxicity risk in the clinical practice is even less than we see with other medications. So it is even safer than using bezafibrates. Now, despite having those clear guidelines available from the UK PBC group, we saw that there was a high prevalence of pruritus, especially in the younger age group or those who had a very high level of ALP. There were lots of inadequacy and inconsistency in the treatment. A lot of patients do not receive the adequate treatment for pruritus, which is one of those disabling symptoms which affects our patients' quality of life significantly. Fatigue is also problematic. It is multifactorial. It impairs the quality of life of our patients. We have to consider other underlying conditions and treat whatever we can. Unfortunately, there isn't any recommended treatment available. Intractable fatigue is not an indication for the liver transplant, and unfortunately, it does not improve post-transplantation. There are different management strategies out there which focuses on treating associated conditions, comorbidities, treating patient symptoms, ameliorating factors which exacerbates the fatigue, provide patient a coping strategy, counseling, and actually showing empathy, understanding that patient has symptoms which is affecting their quality of life. So guideline-wise, they do recommend that patients should be offered a structured lifelong follow-up, recognizing that all patients may have different needs, as we talked about patients with a high risk, those who are high risk of progression. There are a number of risk scores available. There isn't enough evidence to support one over the other, and I don't tend to sort of follow all of them strictly, given the data I showed you earlier, that even the goalpost is now shifting from what we used to say earlier about alkaline phosphatase and bilirubin to now where we are trying to achieve completely normal bilirubin and alkaline phosphatase. So I think this is probably the key slide that I would like all of you to be able to take home, maybe take picture or whatever way you are able to recall it in the future. So we know that the alkaline phosphatase and positivity of AMA is sufficient for the diagnosis. The biopsy and the imaging are not really needed. However, in cases where there's any concern about biliary obstruction, then ultrasound should be able to answer that question. PBC is an inflammatory disease, and ALT is regularly elevated, and overlap with autoimmune hepatitis is not common. Interface hepatitis is not a dollar sign. It is common and frequently predominant feature of PBC histopathology, so not only autoimmune hepatitis. We should therefore avoid misinterpreting AMA negative disease as variant of autoimmune hepatitis, because there's a risk of inappropriately using immunosuppression rather than initiating effective PBC treatment. So early initiation of ursodeoxycholic acid is associated with better response. It has to be weight-based, as 13 to 15 milligram, and higher doses are not indicated. PSC, I hope we're doing okay from time-wise, although it's not justified to spend 2 minutes on PSC, which is regarded as a black box of hepatology. A diagnosis can be made with elevated serum markers, ALP and gamma GT, with characteristic changes on MR, cholangiograms, and when we have ruled other secondary causes of cholangiopathies. When I was thinking about making this presentation, I was trying to look for a patient that I could share with you as a typical patient with PSC. Now, it is really hard to pick up one patient that could really explain all the problems that we come across in patients with PSC, and who would be really suited to summarize all the issues associated with PSC. There's plenty of data out there. So if you look through all these studies, we know that the median survival remains poor. Unfortunately, without transplantation, death and mortality and the morbidity rates also remain significantly elevated. The same is evident from UK cohort, where the patient, especially those who have an intra and extrahepatic stricturing disease, were worse than those who had just extrahepatic disease. Worry here is the lack of effective therapy. Patients presents with symptoms, as you would see with other cholestatic liver diseases. Unfortunately, there's an additional problem here, and that is some may have this significant PSC IBD syndrome. So there are challenges in terms of the management. We can pick up one or the other strategy. However, we know there are a number of new therapies which are in pipeline, but none of them are available as yet. I will spend a few minutes on ERCP, especially we know that lots of us are very keen on intervention. We would like to help our patients using our hands, but this is one condition where I would strongly recommend that we exercise caution. Benefits are restricted to only those who have dominant strictures. We have done adequate initial investigations, cholangiograms, and ruled out dominant strictures. And when we do decide to ERCP, then we do everything that we possibly can do to mitigate the risks of complications. So patients who do not have dominant stricture, cholangitis, or jaundice should not be subjected for ERCP. And we can define dominant stricture in different ways. This is one of the definitions that I use when I'm teaching on training. Patients who do have strictures, dominant strictures with jaundice, cholangitis, cast, or stones can be offered ERCP using all those simple agents that helps to mitigate the risks associated with ERCP. When it comes down to this IgG4 related disease, or when we are not sure about PSC on other available images, or patients who have this indeterminate stricture, we could consider ERCP. However, that has to be done after discussion with the liver centers or seniors with expertise in this field. IgG4 related disease is a minefield, and the differentiation between IgG4 related sclerosing cholangitis and PSC also becomes a challenge, but we can look for simple things. For example, PSC is usually a multifocal stricturing disease, unlike IgG4 related disease. Histology usually it gives the answer in most cases. Steroids works for IgG4 related disease, but not for patients with PSC, and that it's completely opposite for ursodeoxycholic acid. So in summary, if I have to summarize PSC, if you look at these 5 domains, patients presenting with elevated bilirubin, cholangitis, we look for presence or absence of dominant stricture. If it is there, then we try to evaluate if it's benign or malignant. In benign cases, we could consider offering endoscopic treatment. In malignant, we can still offer the treatment, but treatment should be discussed with a liver transplant center or seniors with expertise. For gallbladder disease, we offer these patients annual ultrasound surveillance. The same goes, for cholangiocarcinomas, either suspected or confirmed, discussion with expert centers is important. These patients should not be suspected to diagnostic sampling, such as the US-guided approach. Patients with IBD requires a complete separate session and discussion. This is a group of patients who require special attention, but what we know from the surveillance pathways that the patients require regular surveillance colonoscopies to survey for basically for the cancer, the C word. And metabolic disease also requires special attention, and the same goes in the PBC world. So when we are referred patient for PBC second-line therapy, one of the things that we firstly check is their vitamin D level, and their bone health is also mandatory to be assessed. And the same is true in most cholestatic diseases. There's a very interesting case report published recently in, about the I think elementary pharmacology and therapeutics about rifampicin, the deficiency of cholestasis, fat-soluble enzyme deficiency, which was missed and lead to significant coagulopathy in the patient. So in conclusion, chairpersons, ladies and gentlemen, cholestatic syndromes offer different challenges, but unique opportunities. Importance is to ensure that we risk stratify our patients, diagnose them confidently, start treatment early, and put them on appropriate surveillance pathways. Management is all about optimization and stratification. Thank you for listening, and look forward to your question and answer session.